All right, good morning, good afternoon, I guess it is now that it's turned over 12 o'clock, everyone. Welcome to the Parkinson Society Southwestern Ontario monthly webinar. Today we are very, very pleased to have Dr. Alex Peel joining us from Wingham. And I'm going to get into her biography in just a minute, but Dr. Peel, I have to tell you how nice it is to see a neurologist who is so dedicated to rural communities as you are. I know you service both Huron and Perth and Bruce Grey. And you know, for those of our patients and clients who are in those areas, I know how tough it is sometimes to get into the metropolitan areas. So it's wonderful that you're servicing those rural communities that really do have the people and need the help. So thank you on behalf of all of us. You're a geriatrician, and I wasn't sure what that meant until you sent me a very nice explanation in that it's an internal medicine specialist for people over 65. And I think when we hear geriatrics, we just automatically, you know, assume it's kind of the nursing home set, if you will, or but you specialize in diagnosing and treating conditions that affect older persons. You have a great background. You completed your undergraduate degree at the University of Waterloo in kinesiology, and then moved to your medical degree at McMaster. And then you went on to complete this amazing internal medicine training at the Northern Ontario School of Medicine. Where is that? Is that Thunder Bay?
Yeah, so I actually trained at the Thunder Bay campus, but the Northern Ontario School of Medicine is actually distributed all through both Northeastern and Northwestern Ontario. So Thunder Bay is sort of the Northwestern hub, and then Sudbury is the Northeastern hub.
Excellent. And then you also did your geriatric medicine at the University of Western Ontario. You're, as you mentioned, you care for patients living in Huron, Perth, and Grey Bruce counties who have a referral from a doctor or a nurse practitioner. And you're based in Wingham, where I know I've dealt with some of your team already. They are wonderful. You complement your administrative assistant, Kelly, and registered practical nurse, Melinda. And you're right, they're an amazing team. You work in partnership with the geriatric medicine nurses from St. Joseph's Healthcare in London, which is Diane Fox from Huron County, Alison Hillier in Perth, Rachel Thompson in Bruce, and Karen Burrows in Grey. And those nurses help complete a home visit prior to consultation with you to gather the necessary background information and provide initial recommendations, which I didn't realize that you had that wonderful support net set up. You also collaborate with nursing staff, social workers with the Alzheimer's Societies and Behavior Supports Ontario teams, and senior mental health team in Huron, Perth, and Grey Bruce. And on top of all that, you have time to be a mother, a wife, a doctor, a researcher, and an advocate for the care of older persons in our community. So it is wonderful to have you on board here today. And if you'll bear with me, I'm going to turn over control to you and let you get going with your presentation and get things going. Sorry, this is always the technical part that gets me.
That's okay.
There we go. I think we should be able to turn over control now.
Okay, so I've clicked show my screen, so I'm just gonna just change my displays around a little bit just to make sure that everybody can see my slides properly. So it's going through a little bit of, I'm just, keep the changes. Give me one more second here. My computer's saying you have too many screens open. We don't want you to do that. Okay, you should see my screen now, I think, Mark.
We are seeing it.
Okay.
I'll ask if anybody can't see it, please make a motion in the chat box or in the question box, but I'm not seeing anything at this point, so.
Okay, I keep getting a pop-up from the software just saying that it wants me to install new audio hardware. So I'm not sure how we're going to manage that, but hopefully allows me to silence that. But we'll just get going here. So thanks to Mark for that fabulous introduction. So hopefully we can spend about the next, let's say, 40 minutes talking about some topics related to older adults and Parkinson's disease, and hopefully save lots of time for questions. Okay, I'm still seeing this pop up. Are you seeing my presentation, Mark?
No, I've got the Acuro EMR pop up showing.
Okay, this time I've tried to say I've accepted its sound settings. Hopefully it will go away now. All right, do you see my presentation there now?
I do. That's, yeah.
Okay.
Great. I'm going to put myself on mute, Dr. Peel, so if anything pops up, I'll be in the background.
Okay, super. So thanks everyone for coming, and these are the objectives that I've sort of laid out for the next 40 minutes or so, and then hopefully lots of time for questions at the end. So the first objective is that I'm hoping we can talk about what a geriatrician actually is and what role they might play in your care. The next thing I want to talk about is to understand that although falls are common in older adults with Parkinson's disease, that there are some things we can do to mitigate that risk. And the last thing that I'm hoping to leave you with is just that Parkinson's medications can help many people with their motor symptoms of Parkinson's disease and some of the non-motor symptoms as well, but that as we age, some of these medicines might need to be adjusted, reduced, stopped, etc., to optimize people's cognitive function with aging. Okay. Again, we're just moving some things around here on the screen. So what is a geriatrician? So as Mark was saying, a geriatrician is actually an internal medicine specialist. So that's that specifically works with caring for people who are over age 65. And we sort of focus on the 5 M's. And so that's the concept of looking at what matters most to the person. So thinking about their goals of care and their quality of life. The next thing is addressing things to do with their mind. So that might be dementia, delirium, depression. We look at mobility, thinking about things like falls, bone health, and that's where Parkinson's disease often comes in because a lot of our patients with that condition might have mobility challenges. We look at the medications, so thinking about what medicines are safe to continue, which ones should be stopped, and which ones we should have some particular monitoring on. And then sort of lastly, looking at the multi-complexity, which is sort of how the overlap of all of your conditions lead to the symptoms that a person might be experiencing. So in terms of where we come into the care of a person with Parkinson's disease, what I sort of kind of lay out for people is as your age increases, as your frailty increases, and as the number of maybe non-motor symptoms of Parkinson's that you're experiencing, or falls, or cognitive concerns that you are developing, you may be served well in that type of situation by a geriatrician, as opposed to people that have a lot of motor symptoms, might be younger in age, might be less frail, would be more likely to seek care from a neurologist or a movement disorders neurologist. So let's kind of go into a case just to start ourselves off. So this is Mr. Jones. He's 75 years old. He's had Parkinson's disease since the age of 67. He has high blood pressure and atrial fibrillation, which is an abnormal, irregular heartbeat, and depression. And he's been experiencing difficulties with dizziness on standing for the last couple of months. And in at least 2 occasions in that time period, he's actually fallen due to feeling dizzy. He's taking medications, including levodopa carbidopa 100/25, 3 tabs 4 times a day. Entacapone 200 milligrams 4 times per day, pramipixole 0.5 milligrams 3 times a day, metoprolol for his atrial fibrillation 50 milligrams twice a day, amlodipine 5 milligrams twice a day, which is a medicine that would lower blood pressure, and citalopram 20 milligrams once a day, which is a medicine that would be for depression. I'm just going to try to hide this screen a little bit more. So with this dizziness that he's been experiencing, this gentleman has taken his vital signs, and he's told by the telehealth nurse that his blood pressure is normal, 120 on 82, and his pulse is 62. So in terms of how a geriatrician might approach dizziness in just anyone in general, we sort of lump it into 3 broad categories. So the first one is vertigo. And that's kind of the idea that when you move your head, you might experience sort of a spinning phenomena where you're not even able to sit up or stand up because you have this sort of severe kind of spinning feeling. And it encompasses conditions like benign positional vertigo, maybe you've had a stroke in the balance system in the brain, or a condition called vestibular neuritis, which is a viral infection where people would get this sort of repeated spinning sensation. We then will talk about presyncope, which is kind of the idea of kind of almost passing out, right? And you can think of it, there's a number of causes of that. We'll often talk about vasovagal, which is maybe where you've had some kind of emotional or physical trigger, and that drops your blood pressure and you kind of almost pass out. There is orthostatic hypotension, where you stand up and your blood pressure drops. And there are a lot of cardiac causes. So let's say your heart rate goes too slow, or you've got a valve problem in your heart. You might try to exert yourself and you might feel like you're going to pass out. And then the last group is sort of this general disequilibrium. And so that would encompass people that maybe they have vision issues which affect their balance. Maybe they have musculoskeletal issues like arthritis in their hips or their knees or their back that affects the mechanics of their walking and makes them feel unsteady. They might have neuropathy in their feet where they can't feel their feet and so they feel unbalanced when they're walking. Or perhaps, sometimes people with Parkinson's disease or any neurologic movement disorder, right? Losing their general balance sense can be sort of part of that condition. So, then how do I apply that very general approach to the people that have Parkinson's disease? Because dizziness is just so common in that group. And when I think of that group specifically, I kind of refine, my thinking a little bit about how their dizziness might be, or what might be causing their dizziness. So at the top, I've kind of got medication side effects. And I think that's an important thing to point out. That about 20% of people who have Parkinson's disease, who take the various Parkinson's medicines, will feel dizzy just from those medicines and how they interact with their underlying condition. For many people, that is due to the medicines inducing a drop in their blood pressure and thus making them feel like they might be going to pass out. And for some people, it's just due to interactions with their other medicines, right? So you add in a Parkinson's medicine that drops the blood pressure combined with their other medicines that drop blood pressure, and maybe now you've got really low blood pressure. After I think about could their medicines be contributing to this, I do then think about that concept of orthostatic hypotension, or just general drop in blood pressure with standing. And the reason is about 60% of people with Parkinson's disease have low blood pressure with standing, and that prevalence increases with increasing age. And so it's definitely, after we've sort of looked at their medicines, that's definitely where we will focus a lot of attention. In terms of other factors that can affect people specifically with Parkinson's is because of the postural imbalance that they have, they can just lose balance generally quite easily. And there can be a lot of vision and visual perceptual issues. So they might have more trouble with depth perception, or they might not be able to interpret an obstacle properly. So because this orthostatic hypotension concept is so common, I just wanted to go over some of the symptoms that my patients might tell me about, so perhaps you can relate that to some of the symptoms that you're experiencing. The biggest thing is that your symptoms come on with standing and they improve with sitting or lying down. Some people experience it as a lightheadedness. Some people can tell me that they feel like they're going to faint, or they feel like they're going to fall, or they feel like they're going to pass out. Some people will say, well, I got a headache or a heaviness, or my vision started to tunnel in. Other people will say, I felt just really vague. I felt just really muddled. And sometimes I'll get a report from their caregivers too. You know, they'll say, well, I stood them up from their bed and they looked like they were just going to zone out completely. And like I had lost them completely, and they didn't come back until I sat them down. Other people can sometimes say they felt sweaty, they felt hot, they felt nauseous, that kind of thing. The other thing to think about is what triggered it. So I mentioned standing, but there are other things that can make it worse as well. So our blood pressure is naturally a little bit lower in the morning. So some people might tell me, well, my symptoms are worse in the morning and better in the later in the day. For many people, it's triggered by a big meal or by alcohol consumption. So that might be some, you know, we might say, every time I stand up from the lunch table, I feel that I'm going to pass out. Prolonged standing can do it. So some people say, well, you know, doctor, I wasn't going from sitting to standing. I was just standing at the sink doing dishes. And after about 15 minutes, I just felt that I couldn't stand anymore. I was so weak. And sometimes the prolonged standing will just sort of trigger a drop in blood pressure. The hot weather or standing in a hot shower can do it. For some people, it happens when they're straining on the toilet, when they become ill, or maybe when they're feeling anxious or panicky about something else. So in terms of how you might assess this in yourself or in a loved one, there are many ways of measuring the orthostatic, or it's also known as postural vitals. But what I think, you know, I would encourage you to do is to measure your blood pressure and pulse after you've been lying flat for about 5 minutes. Then stand yourself up and take a blood pressure and pulse at that time, or we say 1 minute after standing, and then take another one at 3 minutes of standing. And if on either of those two standing measures, you see a drop in your blood pressure of greater than 20, that would be diagnostic of this orthostatic hypotension. You know, I have some people that drop 15 and they still feel dizzy, and that's okay too. I have some people that drop a lot more than that. There are some other criteria as well, but I wanted to keep it as simple as possible for you. And if you think that you might be experiencing this condition, you've measured your vital signs at home at various different times and you're not detecting this, some people will go for advanced autonomic testing or tilt table testing, where we would actually take them in a lab, lay them down, elevate them up, and do various other provocative measures to see if they have this syndrome. So what if you're found to have this orthostatic hypotension? What might you do to help, or what might you ask your doctor about? The first thing is thinking about adjusting or stopping one of your non-Parkinson's medicines, or perhaps one of your Parkinson's medicines, because as I said, many medicines can have an effect on blood pressure, including the Parkinson's medicines. If that's not feasible for you, there are some lifestyle things that have been shown in studies to be effective for people. So compression stockings is one, and we think that it probably has to go to the thigh or to the waist to really be effective. If you have difficulties getting something like that on, often I'll suggest an abdominal binder, which is basically like a big elastic that you would wrap around your stomach to try to increase the pressure on veins and boost blood pressure. Another thing I'll suggest is to have people drink a big glass of cold water before they stand up in the morning, because sometimes that's enough to just boost the blood pressure to keep them from falling on their way to the bathroom in the first morning. Exercise can be helpful. And what I mean by that is, you know, before you stand, for example, moving your feet up and down, clenching and unclenching your buttocks repeatedly, crossing and uncrossing your legs, or rising up and down on your toes. Sometimes that can be enough to get your blood pressure up before you stand. Or some people, you know, once they stand, they try to do, some quick marching in place to try to boost up their blood pressure. Other things are you can try sleeping on a 30-degree angle. So for some people, that keeps their blood pressure a little bit lower overnight, and then they don't experience such as large fluctuations in blood pressure in the morning. Some people will bring a walker or a stool with them. So for example, if they're sitting doing dishes and they always get the symptoms, they'll sit on a stool while they do their dishes, and that may help them. You want to avoid triggers like the large meals, hot showers, anything that sort of triggers you. You want to make sure you're well hydrated, so drinking 2 to 3 liters of fluid a day, and getting sort of 10 grams of sodium per day, which is really only a couple of teaspoons when you think about it, but some people are following a low salt diet. And then if all of these other strategies aren't appropriate for you or aren't helping, we often will add a medicine to boost up the blood pressure. And there's 3 different ones which are commonly used. The first one is domperidone, which is added to try to kind of block the effects of your levodopa pill that you might be taking. The second one is fluticasone, which helps you retain water and then boosts up your blood pressure from that. And the last one is midodrine, which clamps down on your blood vessels to try to keep your blood pressure higher. All of these medicines have monitoring and particular risks and benefits in different individuals. So it's certainly something you would want to discuss with your specialist or your primary care doctor. So what about, you've gone through that and maybe orthostatic hypotension doesn't apply to you, but you're still off balance. What are some sort of general things that you can do? So do take a look at kind of all of your medicines, as I mentioned, because some of the common ones that you might take for, let's say, your bladder can make a person feel dizzy or unsteady or off balance. Let's say you take a diabetes medicine and your blood sugar is low. That could contribute to you feeling that way. Maybe you're taking a sleeping pill, which is making you residually groggy in the morning. So just making sure that you've taken a good look at all of those pills. Also, just making sure you take a good look at your over-the-counter pills. So some of the things that we might commonly have in our medicine cabinet can really make people feel off balance, and especially when you have Parkinson's disease. And I've listed some of them here. So Gravol is one, which can be quite sedating for people. Anything that has the word PM at the end of it. Cough syrups, itch medications, muscle relaxants, anti-diarrhea medicines, over-the-counter sleep aids. Those are just some of the few to think about. Other sort of general tips, I know some people love their walking aid. Other people really aren't keen on a walking aid. But, many of my patients get a lot of benefit from using something like walking poles or using a rollator walker to help them with their balance. And if you're not just sure what would be appropriate for you, you can get an occupational therapist either through a primary care contact with your family doctor or through home and community care in Ontario. That's free, and they would be happy to measure you and give you advice on different aids that might be helpful. The next thing that would be important is just looking at sort of other risk factors. So lighting can be important for people. If let's say you're getting up at nighttime, for example, you're trying to get up in the dark, just having a night light may help reduce your risk of falls. Avoidance of bifocals. And so what happens there is that when you look down through bifocals, because it magnifies what you're seeing, it can cause people to have altered depth perception. So if people are really having difficulties with falls, we'll advocate for them getting one pair of glasses that they wear for distance and a separate pair of glasses that they wear for reading. The last thing sort of along that vision spectrum is removal of cataracts. Or just optimization of any vision condition. But specifically, we have evidence that removing a person's first cataract significantly reduces their risk of falls. Moving down the list, looking at your home environment and trying to kind of optimize safety in the home, or getting an occupational therapy home safety assessment has also been shown to reduce people's risk of falls. So on the side here, I have a picture of a beautiful stairwell, but some of the things you might notice are there's no railings in this stairwell. There's a throw rug. There's a little bit of clutter on the steps, which could increase someone's risk of being falling. So sometimes you just need that outside opinion from a therapist as to what you could do to kind of optimize your function. Likewise, sometimes you need other aids, like maybe a raised toilet seat or lowering your bed or something of that nature. Thinking about footwear can be important. I put a couple of pictures here. The first is of a lady who's wearing beautiful shoes, but of course they are high heel shoes, which will increase the risk of falling. And then to the side, I have a pair of slippers. Again, they're great, world's greatest dad slippers, but we generally would recommend something with a solid sole, something that goes all the way around the back of the foot, and Velcro's closed tightly to just reduce the slipping of footwear. Exercise is another intervention which is shown to be very effective. So core and balance training specifically. And I'm going to link to a few of the resources that are available, but that's something very important that you can do to reduce a risk of falling. And the last thing is having a continence assessment. Continence we're not going to talk about too much today, but what we know from the literature is people that experience urinary urgency or nocturia, which is peeing at night, they have a increased risk of falls simply by the fact that they are rushing to the toilet so frequently. And so anything that we can do to reduce the frequency and urgency of their symptoms has actually been shown to reduce the risk of falling. So if you are from the Southwestern Ontario area and you're looking for some resources for falls prevention exercise, I'm sure many of you, as you're well-connected people, know that the Parkinson Society runs a lot of great exercise programs for people with Parkinson's. I've also put a link to the Southwest Healthline website, which has a listing for all of the falls prevention exercise programs in our region in the Southwest. But it doesn't matter where you live in the province of Ontario, falls prevention exercise programs are offered throughout every community as part of a government program. With COVID, a lot of it has been virtual, but those programs are there for you if you're looking to reduce your risk of falls. And I should say as well, they do have a level 1, 2, and 3. And so it doesn't matter whether you're someone who's in a wheelchair or someone who runs marathons, the exercise program can be tailored to various levels. Touching just briefly on bone health. So something that I would commonly see is someone with Parkinson's disease, and they're at high risk of falling. And because of all of their other health conditions, nobody's ever really thought to look into their bone health. So they've never really had a baseline bone density test. And some of these people have actually already broken a bone, and it still hasn't really come to the attention of their healthcare provider. So the thing I would kind of put out to you is, every man and woman over the age of 65 is suggested to get a baseline bone density test. And then based upon your results and your risk of falling, that test might be repeated at some point in the future. We generally recommend that anyone with a bone health concern take vitamin D, at least 1,000 international units a day, and then dietary calcium between 800 to 1,200 milligrams per day. And again, just highlighting, if you have broken a bone before, you're at even higher risk, and I would recommend having an appointment with your family doctor specifically about your bones. So if we think back to the case here of Mr. Jones, he was able to do his blood pressure monitoring at home. And what we see is that when he's laying down, his blood pressure is 120 on 80. And as soon as he stands up, his blood pressure goes to 100 on 50. And then as he continues to stand, the blood pressure actually drops further down to 96 on 48. So what could we do for this individual? The first thing we identified was that urinary frequency was kind of playing into his kind of rushing to the bathroom and his risk of dysbalance. So we were looking at doing some timed toileting, which is the idea of going to the bathroom, let's say every 2 hours before you have to rush to get there, on sort of a schedule so that you don't get so many of the urgencies and accidents. And we were also talking with him about seeing a pelvic floor physical therapist. The next thing that we did was we stopped his blood pressure pills because it doesn't seem that he requires them anymore, and it seems that they're causing side effects. And we also reduced his medicine for atrial fibrillation because it can affect blood pressure as well. He tried implementing some of the non-medication strategies that we discussed. When his blood pressure still remained low and those strategies weren't helpful enough, we started him on a medicine to help with lifting his blood pressure. And so in this case, we actually chose fluticasone because it helps with water and salt retention and thereby boosts up blood pressure. This gentleman got himself into an exercise program. He kind of went through all the falls prevention tips that we gave, and he had a baseline bone density ordered to look at his risk of fracturing when he falls. So we're going to shift gears a little bit, and happy to take any questions about that at the end, but we'll bring Mr. Jones back again. This time he's 83 years old and has had Parkinson's disease since the age of 67. He's now got a diagnosis of orthostatic hypotension, atrial fibrillation, and the previous depression, and Parkinson's. And he's still taking the levodopa carbidopa, 100/25, 3 tablets 4 times a day, the entacapone and the pramipixole. His metoprolol dose has been lowered, and he's taking that fluticasone, which is the medicine to kind of boost up the blood pressure, and still his antidepressant. And what his family has observed is that, he seems to be a little bit more muddled in his appointments. He seems to kind of drift off in conversation. He doesn't always recall things that you've told him. And in the last 6 or so months, he's been experiencing increasing visual misperceptions called visual hallucinations. So in terms of how we would approach this change in thinking and behavior in a person with Parkinson's disease, I've kind of put in what's called the 4 Ds. And in people without Parkinson's disease, we'll talk about the 3 Ds, which is delirium, dementia, depression. But again, because I wanted to just highlight the importance of refining the medicines in Parkinson's as we age, I've sort of put in the 5th D. So thinking about the Parkinson's medicines and how they impact cognition, I just did kind of want to highlight there that about 20 to 40% of people with Parkinson's can experience worsened psychotic symptoms, so that's hallucinations and cognitive symptoms from their medicines. And I've kind of listed the medicines in order at the top where I've got anticholinergics. That's sort of the one that we would look at maybe refining first, all the way down to the ones that are sort of lowest risk at the bottom, where I've got levodopa carbidopa. And then I've got some little icons to the side there where you'll see 3 different ones. So one of them is kind of a confused looking smiley face, and that's to sort of identify that those medicines can cause some confusion. The little 3D goggles that you see, those are the ones that seem to be more associated with hallucinations. And then I've got the little grumpy man, and those are the medicines that seem to be more associated with, irritability, impulse control, those types of things. So if we go to the top and we're thinking about those anticholinergics, such as Artane, that's often started when people are really experiencing difficulties with tremor. But the problem is that as we age, anticholinergics will block acetylcholine in our brain, and that can make people significantly more confused. And so that class of medicines is really often something that we might first look at potentially deprescribing in someone that is experiencing cognitive difficulties. Amantadine is another one. It's lower risk of causing confusion, but if it's not needed anymore for someone's dyskinesia or for their Parkinson's symptoms, we'll look at tapering off. Dopamine agonists is another sort of class that we generally try to back off on as people get older, because it does exacerbate, you know, that irritability and the visual hallucinations and those impulse control symptoms. MAOB, again, it is associated with some hallucinations. You know, the biggest concern for a lot of my patients is all the drug interactions that it might have with their other medicines. So for example, in this patient with their citalopram. So basically, you know, the summary of this slide is we just have to think about the medicines and are they still needed? Are they still helping, or are they having side effects? Then if we think about, you know, the other Ds, the delirium, the dementia, and the depression, you know, delirium is a very acute change in someone's cognitive skills. So that usually comes on within hours or days. It's usually due to an underlying medical condition. And so it is considered sort of a bit of a medical emergency. It's something that you might want to seek help for through the emergency department, or, you know, urgently through your family doctor's office. And we'll touch on that a little bit more. You know, dementia is something that generally develops, you know, very slowly, gradually over months and years. And so that kind of differentiates those two conditions. And then, you know, depression and other mood disorders can be very common in people with Parkinson's disease. And, you know, often I find we might be, let's say, treating a depression, and then over time, you know, we may realize that, you know, maybe this is evolving more towards a dementia. Sometimes it can be a prodrome for future cognitive change. So let's say you're caring for someone with Parkinson's disease and you're noticing somewhat of a sudden change in their behavior. You know, this is a delirium screening questionnaire for families, and it can be accessed through the link that I've provided. And what they've sort of shown is that, you know, if you score more than 4 on this test, when you're sort of checking off symptoms about your loved one, it's probable that they may have a delirium and you should go get checked out. In terms of causes of delirium, I think this is another thing for families to be educated about, because sometimes, you know, providers may not be educated about all of these things that can cause delirium in older adults. The first one is a medicine change in general. So it could be a new medicine, it could be stopping a medicine, it could be a toxicity from a medicine, substance use or withdrawal. So maybe the person is drinking more alcohol, or they've actually stopped alcohol and now they're in withdrawal. Someone might be dehydrated or malnourished, and that can be enough to precipitate delirium in some people. The person might be severely constipated or in urinary retention where their bladder is not emptying, and that can do it for some people. They might have a new medical condition or an abnormal blood work measure, or you know, a systemic infection of some kind. And so that's where kind of getting that medical workup is important. The person might have an abnormal vital sign, so maybe they do have low oxygen or low blood pressure or something, and maybe that's driving their problem. Pain can be a trigger, so, you know, people that have fallen and, let's say, broken their ribs, you know, they can be in severe pain, and whether the delirium gets caused by the pain medicines or the pain itself, it can be hard to sort out, but it's a big trigger of developing delirium in frail people. And the last thing is just a change in environment or a change in routine. Some people that have an underlying cognitive concern, even just a small change in their routine can really throw them off. So in terms of what you can do as a family member, you can call the pharmacy. You can get a medication list. You can look in the person's house, look at their over-the-counter pills that they've got, look at their medication bottles, and kind of bring that with you and say, I found this. Is this something that could cause confusion? You want to look into the substance use. Is there alcohol bottles that you didn't know were there? Or maybe the person is newly using cannabis. You want to look in the fridge, in the garbage can, see, is there food wrappers? Is there dirty dishes? Have they been eating and drinking? Asking them about their bowels and bladder. Just kind of look at the person. Do they look like they're medically unwell? If yes, you should probably take them in to get assessed. You can check a set of vital signs and a blood sugar if you have those monitors at home. And, you can always call a telehealth nurse or your family doctor to go over those results with you. You can ask about pain, and you can just identify, has there been some type of trigger or stressor that might have precipitated this? In terms of, let's say your loved one has been diagnosed with delirium, they are trying to reverse the underlying cause, and they're hoping that the person's cognitive skills are going to come back to where they were before. What are some things that you can do? So the first thing, this is a figure put out by the Regional Geriatric Program of Ontario, and they kind of got it, into 6 steps or 6 categories for families. So one is kind of stimulating the mind. So, providing daily socializing, listening to music, doing brain games and things like that to help the person become reoriented. You want to keep that person moving, so making sure they're walking, regularly through the day. You want to make sure that they're sleeping okay. So let's say they're in a hospital environment and it's loud, sometimes providing earplugs or an eye mask can help the person get to sleep better. You want to optimize their hearing and vision, so make sure that they have their glasses, their hearing aids with them. You want to then make sure that they're getting proper nutrition and hydration. Again, in a hospital setting, sometimes the nursing staff might not notice that someone didn't finish their tray, for several days. And so, it can really be on families to notice, like, this person didn't eat and drink properly. So kind of shifting, quickly into the last topic, I often get asked, what's the difference between normal aging versus dementia? And you can review this slide for yourself, but the biggest thing is that people who are aging normally can sort of manage their own affairs. So even if they're experiencing a short-term memory difficulty or they're having trouble with slowed processing speed, they can usually manage their finances, or at least delegate that, manage their medicines, make a grocery list, those types of things. If the person is not able, that suggests that they are developing some type of cognitive disorder. I then get asked a lot, well, what does it mean to have dementia, or what kind of dementia do I have? And, I just wanted to highlight that, dementia is kind of an umbrella term. It means that you've had a change in your thinking or behavior combined with a change in your functional ability. So that's where that driving or managing pills or managing finances or making meals, etc., might come in. And then there's many kinds of dementia sort of underneath the umbrella. And so one is sort of the Lewy body disease category, and that's where you would find Lewy body dementia, Parkinson's disease related dementia. So, another thing families will often say to me is they'll, say, well, I don't think my loved one has dementia because, their memory is good. Yeah, they're having trouble in other areas, but, their memory is good, doctor. And the thing to remember is that, in Parkinson's disease, the memory can be good for quite a long time. And often it's some of these other cognitive domains that might suffer, which is a little bit different than Alzheimer's disease. So they might have trouble with planning, decision-making, multitasking, controlling their emotions. So they might be, kind of more irritable than what they ever were. They can have some of these psychotic symptoms commonly. So that can be hallucinations. which is, seeing something. Usually it's visual, but there can be smelling things or hearing things. They might have delusions, which is sort of fixed false beliefs around things, or paranoia, where there's unrealistic blaming type beliefs. So they blame someone for something that doesn't make any sense. There can be slowing of cognitive processes in this condition. There can be a lot of visual spatial issues, and also poor attention is a big feature. So, the next question that people ask me a lot is they'll say stuff like, well, one doctor told me I had Parkinson's disease dementia, and another doctor told me I have dementia with Lewy bodies. Which one do I have, right? And, I think I'm hoping that this slide kind of illustrates the answer for you. And I think the answer is, it is a spectrum of illness, and it probably doesn't matter so much exactly which label you get, because the treatment is similar between a lot of these conditions for the most part. How it's been defined historically is if a person develops Parkinsonism and dementia within the same year, that's generally considered dementia with Lewy bodies. And if someone develops Parkinson's and they have Parkinson's for greater than 1 year, and then they concurrently develop dementia, that's considered Parkinson's disease dementia. Now, again, what we now know is that these illnesses are sort of on the same spectrum. So what this figure tries to highlight is if you have, a person with pure Parkinson's disease at one end, they tend to have a lot of this alpha-synuclein deposit in their brain. And if you have someone with pure Alzheimer's disease at the other end, they tend to have a lot of these beta amyloid deposits in their brain. And when you sort of look at people that have Parkinson's disease, and let's say they got a dementia within 2 or 3 years, we know that they often have an overlap, right, of some beta amyloid. And what we see in the people with dementia with Lewy bodies who get Parkinsonism and dementia kind of within the same short period of time, clinically as 1 year, they often have a lot of this amyloid deposition as well, combined with the alpha-synuclein. So just to sort of say that these diseases have a lot of the same pathology, it can overlap, and depending on exactly how much of which, you might get a different label, but there's a lot of similarities. As we develop more agents that might help target or prevent these conditions, we probably will see a change in this diagnostic criteria. Because as you can imagine, if you're giving a drug that's going to reduce alpha-synuclein, but the person has mostly beta amyloid, that's not going to help them. And so we will need to refine this more, as research evolves. So let's say you're diagnosed with dementia. What are the things that you can do? I just kind of wanted to outline that there is a lot of modifiable factors that might determine someone's cognitive trajectory. So, things that are important are optimization of their other medications and their other health conditions, cognitive training, being socially active, making sure the person has enough support at home, optimizing hearing and vision, minimizing substance use, having proper exercise and nutrition, talking about medicine specifically for dementia, and making sure that we've done some support and education for their caregiver. So last little gear shift, because hallucinations are common or relatively common as the trajectory of Parkinson's would progress, I wanted to talk just briefly about how a caregiver might manage this emotional change that some people experience. And I sort of think of it as a three-pronged approach. So the first is kind of that education and support for the caregiver. And the reason is because the person with dementia can't change their behavior. Only the caregiver can. And so there's tips that we can teach a person to help them manage these things better. There is a role for medicine, and then just making sure that the person has enough respite care and personal support care so that their caregiver has regular breaks. So in terms of how you might comfort a person who's experiencing a visual hallucination, I would say it depends a little bit on whether the person has insight into the fact that the hallucination might not be real, or if they lack insight. If they have some insight, sometimes you can just reorient them and reassure them, and they'll be fine. But lack of insight can often become a problem as the disease progresses. So how you might handle the lack of insight situation would be remaining calm and using a very gentle tone of voice, as opposed to becoming irritable, agitated, shouting with the person, for example, to try to get them to agree with your point. You want to use eye contact, use a comforting touch, like a hand on the shoulder, something like that, to portray comforting body language. And then you want to, or I guess you say, you don't have to agree or disagree with what they're saying, but simply acknowledge what they are saying and reassure them that you are going to help them. So as an example, in this case, your spouse rushes out of the bedroom shouting, "Snakes, there are snakes all over the bedroom floor." I would avoid saying, "There are no snakes, go back to sleep," because that tends to make people feel more agitated. You could try something like, "I know you see snakes on the floor and that you're scared, but I'm here and you are safe. Why don't you go to the kitchen and get a glass of milk, and I'll go check the bedroom." So then, after maybe you've used that type of strategy of, acknowledging and reassuring, how can you prevent this from happening again? Optimizing vision and optimizing hearing. Because often when people can't see properly, they're more likely to misinterpret their environment. You want to look around the room and try to see through the person's eyes and try to think about what might be triggering them. So in this picture, the person is seeing a reflection from a coat rack, and that might be making them think there's a man in their bedroom. You want to try and eliminate triggers. So today I have a person that when they see themselves in the mirror, they believe there's another man in the room with them who's trying to harm them. So sometimes you might want to remove that mirror or cover it. You want to optimize lighting so that you can get rid of these shadows, or have a night light. And then I would encourage you to kind of keep a little diary so that you can share your findings with the doctor and help kind of troubleshoot through these problems. So very last slide, I promise. So what about a treatment for Parkinson's disease-related dementia? So the cholinesterase inhibitors is sort of the first class of medicines that we will use. And what I find for my patients is it has to be sort of a risk-benefit discussion as to whether they would like to try that medicine or not. At the bottom, I've kind of listed there are some contraindications to the medicine. So let's say you have a slow heartbeat, for example, you may not be a candidate for that medicine. The factors that would sort of put in favor of trying the medicine is sort of about 1 in 19 people who take the medicine seem to see some overall sort of global improvement. And the studies have been a bit mixed, but many have shown that people have a reduction in their visual hallucinations and psychotic symptoms from using a cholinesterase inhibitor. The downside is about 1 in 6 people with Parkinson's disease get significant nausea from taking these medicines. There's a small proportion of people that might get a worsening tremor. And then there's a number of other side effects which these medicines can cause. So just simply to say, it's always a risk-benefit calculation. So to Mr. Jones, thinking back to that first D of how drugs might impact that, he tapered off his pramipixole. He saw his doctor and they did a number of investigations to rule out delirium. He was ultimately diagnosed with Parkinson's disease dementia. His spouse got some caregiver education and support with how to manage the complex emotional changes that he's experiencing, and he did start on a cholinesterase inhibitor for his symptoms. So I hope that I have sort of met the stated objectives, and if you do have any more questions for me, you can feel free to share them with Mark and he'll share them with me. I do have a website, a Facebook page, and you can telephone my office. So thanks everyone for your attention.
Thank you, Dr. Peel. That was wonderful. I'm going to leave your screen on just in case you need to access any of your your slides, because we do have a number of questions.
Okay.
And the first one comes from Denise, and she asks, what does avoidance in falls prevention refer to?
Avoidance in falls prevention. So, I mean, I will just skip, I'll go to the slide because I'm not sure exactly what were you referring to this slide, Denise? I'm not sure. So generally, like avoidance just refers to avoiding any triggers. Like I have one person, for example, that always trips over their cat. So, they've actually created a separate little walking area for the cat. Or the picture here, I have someone who's spray painted their dog because they were always sort of tripping over the dog. So I think avoidance, I'm assuming if what I've sort of talked about is just around just avoiding triggers.
Okay, great. Next question was also from Denise, and she asks, is the vitamin D dosage of 1,000 IUs per day just for Canada, or would it be the same? Sorry, I'm just going to get the question out. It kind of ends at that point. Would it be the same I'm going to assume it's internationally.
Yeah, and that I honestly don't know what different countries recommend. The guidelines I'm giving you are related to Osteoporosis Canada. Certainly, we know as a person becomes closer to the equator, they do get more sunlight, they do have more vitamin D synthesis in their skin. So it's possible that other countries might have other recommendations, but I don't know.
Okay, wonderful. Now, Brian has a question. He's asking read differential diagnoses. Example, he used the example cardiac versus Parkinson's,
Mm-hmm.
the medications and symptoms. How do you or can you diagnose this, and does it matter?
Is Brian meaning in terms of the diagnosis of Parkinson's disease or the diagnosis of what's causing someone's disbalance, for example?
I'm going to suggest probably the disbalance.
Okay. Well, I mean, as a geriatrician, what I generally do is I talk to both the person who has the illness and I also talk to their caregiver. Because I find, having two perspectives on what's happening can be helpful. Because one, the caregiver might see something different that the person doesn't see. I also find it really helpful to look at a temporal relationship. So some people say, I was fine, and then I started, XYZ pill, and then I've started to experience the symptoms after that. Making a really good history of, what are the triggers? When do you find it better? When do you find it worse? Even having a person keep a symptom diary, and then just kind of doing the physical examination. I have to say, a lot of times I tell people that their disbalance or their falling is multifactorial. So I'll say you have a bit of blood pressure, you have a bit of medication concern, you have a bit of disbalance, you have a bit of visual misperception, and we'll just come up with sort of a treatment plan that suits that individual and their particular needs, knowing that we may not be able to say, it's exactly this, and if we just fix this, you're going to feel better. Right? Because a lot of times some of these things are not reversible, but we can mitigate and we can prevent, right? And we can optimize quality of life.
Okay. Michelle has a question. She asks, will Parkinson's disease eventually lead to include dementia on delirium, dementia, and depression?
Will Parkinson's always get all of them? Is that kind of what she's asking, do you think?
I'm thinking probably.
Okay. So I guess, I presented those kind of those 4 Ds as just sort of thinking about different buckets of organizing symptoms. In terms of, do people with Parkinson's disease get depression, let's say? What we know now is that changes in people's emotional health can be part of the non-motor prodrome of Parkinson's disease, or it can affect them, at any point during their trajectory. So for a lot of people, that's a condition that we're co-managing. When it comes to dementia, what we sort of know is that people that have Parkinson's disease onset in their 80s and let's say 90s, even late 70s, are more likely to develop dementia, and the percentage rates can be quite high. There are some people with sort of a young onset Parkinson's that have symptoms for a lot of years. Some of them do progress on to dementia and some don't, and we're not exactly sure kind of why that is. But certainly it isn't everyone, but it is a large chunk of people. In terms of who gets delirium, there are a number of risk factors for delirium, of which certain things like having a diagnosis of dementia is one risk factor, right? So many of my patients that have dementia will have periodic episodes of delirium. And some of them recover back up to their dementia baseline, and other ones, they sort of don't get a recovery. And a person, the other side of that is, you can have a person, they can experience delirium, let's say after they have a gallbladder surgery while they're in the hospital, but, their cognition will come right back up. That person might not ever be diagnosed with dementia. So it really just depends on, I guess the particular stressor that you put on the person. And then sort of the drug side effects, again, it's relatively common, but it isn't everybody. So hopefully that answers her question.
Okay, and she had a quick follow-up, just asking that you could repeat the dosage for vitamin C for osteo.
So it's so it's vitamin D, and it would be 1,000 international units per day.
Excellent. We have two more questions, and I hope you'll indulge us. Donald asked, if one has several instances, say 6 over 3 years of RBD, how likely is it the person has Parkinson's disease? And this is what resulted in, he makes a note that Alan Alda from MASH found out he had Parkinson's as a result of this.
Yeah, so I have lots of hidden figures in the presentation here. Let's see if I can unhide. From current slide. So I'm not sure if that still kind of came up, but again, we're getting lots of error messages. But what we know is that there is sort of a long prodromal phase of Parkinson's disease. So you can sort of see in this figure, it's got kind of symptoms and it's got time along the bottom. And you can see kind of the REM sleep behavior disorder is one of the very earliest symptoms that many people will experience. I can't give you a percentage just simply because I just don't have it. I don't want to give you the wrong answer. But we know, for example, that like if you have the combination of REM sleep behavior disorder and autonomic dysfunction, which can be that orthostatic hypotension or maybe bladder issues, or that's probably a separate lecture. But if you have the REM sleep behavior disorder, the autonomic dysfunction, and loss of smell, so those three, your chances of going on to progress to a Parkinsonian or to Parkinson's or another Parkinson's syndrome is very high. And so we are starting to see some people that are sort of diagnosed in a prodromal kind of state. In terms of the average person, REM sleep behavior disorder, so the idea of kicking and punching and acting out your dreams, it is, or I guess I should say, it can be precipitated by, let's say medications. So, a normal person who gets depressed and takes an antidepressant can get REM sleep behavior disorder, for example. So I don't think that, having 3 discrete episodes over a couple of years is, a strong marker that you're going to go on to develop something. It maybe there's a susceptibility, but there can be other triggers, I guess, is kind of what I'm saying.
Okay.
Yeah.
Yeah, sorry, Brian, we've got 2 more questions, if that's okay.
I'm not in any particular hurry, Mark, so you can just
okay. Brian asks you to talk about the use of domperidone for those with cardiac problems.
Yeah, so I'm assuming Brian's maybe alluding to the whole concept of QTC prolongation. I'm just sort of sort of thinking. So how to explain that? So basically, you know, as your heart like generates beats, right? It has like a little generator and it spouts out the electrical signal, and that signal travels through the heart and then, you know, stimulates the heart to beat. If you take certain medicines, it will slow that conduction through the heart. So that can become problematic if you slow the conduction too much, right? Because slow too much, that means, you know, no heartbeats. So we don't want to see that. So domperidone and many other medications can prolong that conduction. So for example, you know, the cholinesterase inhibitor that we talked about, it is a weak drug that can do that. The SSRIs, for example, for depression, they can do that. Let's say you're going to add in then a cardiac medication, perhaps it might do that. Then you might be adding in, I don't know, a sleeping pill, and maybe it does that too, right? And all of a sudden you end up with a big drug soup, and that might really prolong the conduction. So I think, you know, the use of domperidone, it has to be interpreted in the particular individual's context and the other drugs that they are taking, and just kind of doing that ECG of their heart, which gets a, you know, an electrical tracing, which can look at the speed of the electricity. And then that can help you to determine whether domperidone would be safe for you or maybe not safe for you, and maybe you should use one of the other strategies.
Excellent, thank you. Final question, promise. This one's particularly, I think, pertinent for our rural communities. Someone has asked, for those who don't have or may have lost their primary care physician, but who may be experiencing symptoms, what's the best course of action to get a diagnosis or referral?
Yeah, so that's a complicated issue because a lot of the healthcare system, right, it's based upon having primary care and having this hub of primary care, and then all of your specialty care sort of goes out from that. You know, it does depend a little on where you live. So for example, here in Perth, there is a nurse practitioner team from the Here in Perth Healthcare Alliance Hospital that cares for people that don't have a family doctor until they find their family doctor. So some communities might have a person like that who could see you and who could generate a referral to a specialist. And then that specialist could then take on the diagnosis and management of your movement disorder. Other people, they might just even go to a walk-in clinic or an emergency department and just say, you know, I'm experiencing these symptoms. I don't have a family doctor. I wonder if I should see a neurologist or a geriatrician. And, you know, that emergency room doctor or walk-in clinic doctor might kind of generate that referral for them. I also have patients that I hear about them from home care, right? They might be followed by a care coordinator from home and community care, and I'll get a telephone call, you know, saying, you know, can you see this person? They're really not doing well. They don't have a family doctor. And so sometimes, you know, we figure out a strategy to get them a referral. So that might be another avenue. So hopefully that helps that person. They can also call the office, and my secretary will help them navigate that as best as she can.
Wonderful. Dr. Peel, thank you so much. I'm going to take the screen back, just back to our technical issues here. But thank you so much for your time and the willingness to answer the questions and just impart the knowledge that you've given us today. You know, as I mentioned to you in our previous conversation, our Parkinson's patients and caregivers and care partners are an amazing group of people in Southwestern Ontario who take responsibility for their disease. But it's always wonderful to have such a supporter like you, you know, in front, helping us out and working with our patients and helping them get through the times that, you know, can be quite scary, especially when you receive those first diagnoses and have those questions. So on behalf of all of us, you know, I want to just thank you and say how proud we are and glad we are to have you as part of our community.
Well, thank you very much, Mark. It's an honor to be here. I appreciate you asking me. I know, you know, I mean, classically, this disease, it's, you know, it is dominated by neurologists and movement disorders neurologists, but I think, you know, for some patients, there is a role for, you know, geriatric medicine just depending on the age and the level of frailty and the comorbidities and the symptoms that they might have. So hopefully that helps people to kind of understand what role we play.
Well, we do appreciate it. For everyone still in attendance here, I have to do a couple PSAs, and please bear with me. First of all, we've had a number of people on the question screen ask if your slides will be available, to which I can let everyone know that they should be on the Parkinson's Society website. That's www.parkinsonsociety.ca by Friday. So the presentation has been recorded and will be shared. We also have a Living Well conference coming up on April 24th, which will be our next virtual event. And that's got some incredible speakers, including representatives from the new Parkinson's Avengers Advocacy group. So we're looking forward to welcoming everyone there. Coffee Clatch for those that attend, which is it's a great support group, Dr. Peel, for those with caregivers, care partners, or with Parkinson's. That has been extended until June now, which it was supposed to end at the end of March, and it's had such a great group. We've extended it till June, as well as, of course, all of our support groups that are available. And then finally, we want to thank everybody, our monthly donors, our local community foundations and United Ways, our healthcare professionals, our caregivers, and our patients for their support and for allowing us to provide the educational webinars to everyone attending. So on behalf of everyone here, please stay safe, wash your hands, keep everything in mind when you go outside, but stay healthy, and thank you for attending. Okay.